Next in our topic is the oral pre-malignancy. However, before diving into the topic of pre-malignancy, I would like to share a basic topic of dysplasia. So, what exactly is dysplasia? So, dysplasia is an indicator of potential likelihood of progression to malignancy. So, why do we say that the presence of dysplasia can indicate the likelihood of progression to malignancy? Because dysplasia is associated with mutations which involve the epithelium, and microarray studies have suggested that substantial genomic change is present in the dysplastic epithelium. So it clearly means that more dysplastic an epithelium, more likely that the critical mutations that are linked to malignant transformation will be present. But however, only a minority of lesions that show dysplasia actually progress to malignancy. And we also note that carcinomas may arise in the epithelium not showing any dysplasia. So whether dysplasia is present or not is not a guarantee of carcinoma developing, and it is not necessary that dysplasia has to be present for a carcinoma to develop. So now what exactly will I see on the slide that shows dysplasia? So which slide I will say that dysplasia is present? So in dysplasia the cells will show pleomorphism, there will be a large hyperchromatic nuclei, the cells will show higher nuclear to cytoplasmic ratio, there will be architectural disarray, there will be loss of orderly differentiation and abundant mitotic figures. So this is the normal epithelium. The cells are arranged normally with small normal nuclei that is in the center, so the polarity is also maintained. The nuclear cytoplasmic ratio is okay here, there is no pleomorphism. As compared to this side, we can see that there is pleomorphism. We can also see that the nuclei are large, so the NC ratio is increased. Also, there is loss of orderly differentiation. So this is dysplasia. So now if we translate it to a picture of an epithelium like this is normal, where the cells are all the normal size and shape and the architecture is maintained. However, in the image down here we can see that the cells are arranged haphazardly, they are large, they are hyperchromatic. So if these changes are limited to the lower 1/3, it is called as mild dysplasia. However, if this change is spread to the middle third, then it will be called as moderate dysplasia. And if these changes are throughout or full thickness, then it will be called severe dysplasia. Severe dysplasia, now the author Fletcher has clearly mentioned that in the oral cavity, carcinoma in situ word is synonymous with severe dysplasia. So now we'll look at the details of leucoplakia. So what is leucoplakia? First we'll see what is the definition of leucoplakia clinically. So it will present as a white patch or plaque which is not less than 5 mm in diameter. Most important, it cannot be removed by rubbing and it cannot be classified as any other diagnosable disease. So if we see other organs like larynx, then it is equivalent to the word keratosis. On clinical grounds, we can divide it as homogeneous, non-homogeneous, which includes speckled, nodular or erythroleucoplakia. Erythroplakia, where the lesion is red in color, and the proliferative verrucous, which is an aggressive form. Most commonly, this involves the buccal gingival gutter and the tongue. However, it can be seen throughout the oral cavity. So now as a clinician, your question is, why do you want to biopsy these lesions? Because you want to exclude the possibility of carcinoma that is already present. You want to exclude that. And what is the role of me as a pathologist? So I have to assess and grade dysplasia if at all it is present. Now, so what is the clinico-pathological correlation? So the clinical appearance of erythroplakia or a red patch is more likely to be associated with severe dysplastic changes than that of a homogeneous leucoplakia that is white in color. And the term erythroleucoplakia, wherein we see both white as well as red patches or speckled appearance, holds an intermediate position. Second point is the presence of induration. So presence of induration almost always means stromal invasion or the presence of a carcinoma. Also, the probability of dysplasia is much higher for lesions that are located on the floor of the mouth. Now we also have some false positives wherein there are situations that may cause cytological atypia that mimics dysplasia. So cytological atypia is present but it is not dysplasia. So what are those conditions? They can be infection by Candida albicans and nutritional deficiencies like iron, folate and B12. It can be reactive in nature because of infection. Now there are two more lesions that I want to consider in this video itself. The first is the proliferative verrucous leucoplakia. Like I mentioned, it is an aggressive type of leucoplakia and it has a relentless course. So it has to be clinically correlated before giving out the diagnosis. Next is the hairy leucoplakia, where the word leucoplakia is used because it also presents as a white patch. It is however does not show dysplasia and it is not pre-malignant. So what causes this? It is seen in HIV positive patients. It is restricted to the lateral aspect of the tongue and most commonly it is caused by Epstein-Barr virus. So again I would like you to remember that hairy leucoplakia does not show dysplasia and there is no evidence that it is pre-malignant.